Namaste. A very, very good evening, doctors, and a very warm welcome to today's webinar. I am Dr. Srikanth, National Manager Scientific Services, Himalaya Wellness Company, Bengaluru. I will be the moderator for today's webinar, Menstrual Irregularities, When to be Alert. Once again, I extend a very hearty welcome to all of you. And it's my privilege and pride to welcome and introduce Dr. Chandravati Madam, our today's speaker. I'll just give you a very brief introduction. Her educational qualification is she has done her MS and DGO. Apart from this, she is currently Professor Emeritus, Department of Obstetrics and Gynecology, KG Medical College, Lucknow, Proprietor Director, Krishna Medical Center, Lucknow, and also Managing Trustee of Krishna Education Foundation, Lucknow. She's also Secretary of the NGO of WHEEL, Women, Health, Empowerment and Education, based at Lucknow. She is a patron of Indian College of Maternity and Child Health, NARCHI, and UPCOG. Also, she is a director of Private Nursing Home Association, Lucknow. If I have to just have a glimpse of past engagements, she was a HOD of Department of Obstetrics and Gynecology, KGMU, and just now I learned that she retired way back in 2000. And she's having experience of more than 5 decades. I think 59 years to be precise. That's wonderful, ma'am. She was also Vice President Foxy from 2001-2002 for about 15 years. Then she was Governing Council member of ICOG for 2 consecutive terms, peer reviewer Journal Committee for ICOG for 5 years, and she has organized more than 20 state, national, and international level conferences as well. And if I have to make a list of her academic and professional awards, it will take quite some time. So several of her lifetime achievements awards include UP Nursing Home Association Award, UPCOG Award, Indian Fertility Society, Management Association, Padma Shri Dr. Raj Bavela's Lifetime Achievement Award, and IOG or Dr. Satyapal Lifetime Achievement Award as well. Research and publications, more than 65 papers have been published in national and international journals. And she has guided over 115 theses of post-graduation students in KG Medical College, Lucknow. It's indeed my pleasure to once again welcome you, ma'am, for your session today, Menstrual Irregularities, When to be Alert. Please note the question and answer session will be at the end. So please, you can key in your questions in the chat box. We'll make a list of them and let us avail this opportunity of one of the senior most and very prominent gynecologists of the country. Ma'am, over to you.
Thank you, Srikanth, for such a wonderful introduction. It really is nice to hear about yourself, but I do hope that today's session is really fruitful for all my listeners who have really joined today. And I feel happy to be talking on a very, very important subject like menstrual irregularity, because there was a time people did not want to talk about menstruation at all, and how we have been now making people aware that to talk about menstruation, about its irregularity, about its complexion is very, very natural, and one should not hide, because once you hide it, maybe you're hiding some underlying cause and disease. So I will be sharing my slides from here by end, and we will start the talk as soon as my slides are viewed. So we are going to talk about menstrual irregularities, and really the purpose is to talk about when to be alert. What is menstruation? Really, we want to know what is menstruation. It is a physiological condition which is a part of every female's life, and this is a condition which is governed by hormone levels, and there are many multiple factors play part into the start of menstruation. The normal menstrual cycle, usually this starts normally from the age of 11 to 13 years and lasts till the age of 49, or even sometimes it can extend up to 50, but 49 we take as normal. Rarely it happens that cycles may start at an early age, but it is seen that in Western countries, probably because of the effect of the nutrition, the lifestyle changes, the menstruation starts at an early age. Here also, because of sometimes increased BMI, sometimes environmental changes, it might start in an early stage, but normally we take it as from 11 onwards. The normal time is from 13 years, but if it doesn't start by 15, we really get worried. The normal cycle are of 28 days, plus minus 7 days, which means from 21 days to 35 days would be taken as a normal menstrual cycle. If you see the menstrual cycle here, the chart given over here, you can see that from 1 to day 7, the uterine lining breaks down and menstruation occurs. From 8 to 11 days, the lining of the womb thickens and prepares for the egg. 12 to 17 days, ovulation time, and usually the common average time is 14 days. If by chance fertilization occurs, then the corpus luteum takes over the function and the endometrium keeps on thickening. If implantation occurs, then pregnancy occurs and there would not be any withdrawal bleeding. But if implantation has not occurred, the corpus luteum degenerates and the estrogen and progesterone are withdrawn. The uterine lining detaches and there's a breakthrough bleeding and menstruation starts. Here also diagrammatically it has been explained that from 1st to 5 days, the uterine lining breaks down and the menstruation occurs. From day 8 to 10, the uterine lining starts thickening again. Then mid-cycle, ovulation occurs and uterine endometrial lining keeps on thickening. From day 19 till 28 days, the uterine lining continues to thicken until unless pregnancy has not occurred, the corpus luteum degenerates and the estrogen and progesterone are withdrawn, the endometrium lining breaks down and the menstruation starts. Now, what are the menstrual irregularities? Menstrual irregularities refer to any type of irregularity at the onset, which means there's delayed onset of the menarche. The girl has not attended menstruation till the age of 15, and that is a worrisome thing. Or there's problem into the menstrual cycle, which are too frequent too short or delayed, or there are changes into the duration of the flow or amount of the flow, and there's changes in the volume of the menstrual blood loss. Now, these menstrual irregularities could be ovulatory or non-ovulatory. So women can have two types of cycles. They could be ovulatory cycles, they could be non-ovulatory cycles. Now, early part of adolescent, which means from the age of 13 till 16, most of the time the cycles are anovulatory or non-ovulatory. And similar things happen during perimenopause, which means after the age of 40, many times the cycles become anovulatory or non-ovulatory. Ovulatory cycles are usually into the reproductive age group from 17 to age of 40. So we have to find out what type of menstrual irregularity the woman is facing. How common is the problem of menstrual irregularity? The studies from India conducted in 2017 and 18 showed the prevalence to be, in 2017 they found 35.7%, and 18 they found 23.3%. The other studies were done from Asia, 2015-16. They revealed even a higher prevalence. 2015, they reported 38.7, which was quite high. But 2016, unexpectedly, they reported a very high prevalence of 64% of menstrual irregularity. Maybe there was some change in the data collection or the population change which showed this high prevalence. Now, what is the real pathogenesis of this menstrual cycle, how this menstrual cycle occurs? And then we would understand how this menstrual cycle is really being affected. We can see here that there's a hypothalamus which produces GnRH, which acts on the anti-pituitary, which produces very two important hormones, FSH and LH. Now these two hormones then act on the ovary in return to produce estrogen and progesterone. And these estrogen and progesterone act on the uterus. And as I told you, the menstrual cycle starts from coming down of levels of estrogen and progesterone, acting on the uterometrial lining, breakthrough of the uterometrial lining, and menstruation starts. And then the effect of hormones, FSH and LH, estrogen progesterone rises, endometrial lining start thickening, another process, as I told you earlier, it starts. So there's a complex series of interaction involving the hypothalamus, the anti-pituitary, and the ovaries. Interruption of the hypothalamic pituitary axis pathway results in an irregular menstrual cycle. Now, the problems that should not be ignored, because any change into the menstrual cycle could be indicative of some problem into the later life. This type of changes in the menstrual cycle can affect the young adolescents, students, making them miss the college and school. It may have long-term effect in the form of infertility, osteoporosis, and especially cases of PCO can lead to diabetes and cardiovascular disease. Now, if this is a problem, it is important to know what are the major contributing factors. The actual cause we will be discussing, but some common conditions can be contributing factors for menstrual irregularity, like anemia, stress, some genetic factor, and some nutritional habit. We have to be very careful about the type of diet the youngsters are taking, the adolescents are taking, because that can contribute to a lot of conditions. The causes of abnormal bleeding could be some cause connected to pregnancy, immaturity of the hypothalamic pituitary ovarian axis. It could be hyperandrogenic and anovulation. Anovulation, such as PCOS, congenital adrenal hyperplasia, some of the androgen producing tumors, coagulopathy, hypothalamic dysfunction, cases of hyperprolactemia. It may be plain prolactemia, or it could be microadenoma pituitary, thyroid dysfunctions, primary pituitary disease, primary ovarian insufficiency. Sometimes you cannot find any cause, and there could be abnormal uterine bleeding. Sometimes menstrual irregularity could be because of the medication the girls or the women may be taking, uterine lesions, and malignancy. So once we know all these causes, it is very important for us to really work up and find out the cause of the menstrual irregularity. Now, what are the clinical presentation? The menstrual cycle may be normal, or there may be bleeding for less than 4 days, so it may be scanty bleeding, or it may be for more than 7 days. So clinical presentation may be longer or shorter periods. It may be painful periods. The client may be giving history of passing huge clots, which means there's excessive bleeding. There may be heavier or lighter blood flow. There could be early or late periods. There could be missed period. For many months, periods have not come. But it could be associated with some of the other conditions. Some may complain of breast tenderness, and this is, we know, because of the excess of estrogen hormone. There could be history of fluid retention during premenstrual period. Some may complain of headache, vomiting, migraine, nausea. So all these clinical presentations may be there during menstrual cycle. Now, what are the common menstrual irregularities which we have to deal during our clinical practice? One is amenorrhea, which means periods have stopped or periods have not come. So there's amenorrhea, which we'll be discussing. There are two types of amenorrhea, primary and secondary. It may be oligomenorrhea, very scanty, infrequent menstrual cycles. There could be menorrhagia, which means excessive prolonged bleeding during regular menstrual cycle. The cycles are regular, but there is excessive and prolonged bleeding during menstrual phase. There could be dysmenorrhea, which means there could be pain associated with menstrual cycle. Now, this dysmenorrhea could be premenstrual, which means before the period, during menses, menstrual dysmenorrhea, or sometimes it can extend into the post-menstrual phase also, which is known as post-menstrual dysmenorrhea, and this all may happen. Then additional menstrual irregularities could be in the form of polymenorrhea, very frequent cycles, or there could be irregular menstrual periods with cycle-to-cycle variation of more than 20 days. There could be shortened menstrual bleeding of less than 2 days in duration. The patient bleeds for 1 to 2 days only and is scanty. And one very important cause is, or type of bleeding is, intermittent menstrual bleeding or spotting, which many a times takes you towards the diagnosis of sometimes polyps or uterine lesions. Now, first we'll take this amenorrhea, and as I told you, the menarche should start by the age of 13. But if the menses have not started by the age of 15 or more than 3 years onset of secondary sexual development happened, we should take it as an abnormal. But there's amenorrhea and there's even sexual characters have not developed, then it is more alarming. So this is a amenorrhea, and for this we need to take a careful history and examination. In adolescents, pregnancy should always be ruled out. We should rule out disordered eating patterns and weight gain, excessive weight gain, and review with the growth chart. Now here we have taken a chart for the differential diagnosis of amenorrhea, and here primary and secondary amenorrhea both have been taken. Primary, as I told you, that the periods have not started, and secondary amenorrhea is one where patient had been menstruating and suddenly due to some reason her periods have stopped. Now central means hypothalamic pituitary hypogonadotrophic hypogonadism with low FSH. So this could be constitutional delay. It may happen in chronic illness, especially prolonged malabsorption syndromes and other diseases. Functional hypothalamic amenorrhea, There could be pituitary tumors, it could be iatrogenic, and sometimes it could be a congenital cause, which may be because leading to hyperfunction of the hypothalamus and pituitary. In secondary amenorrhea, there could be functional hypothalamic amenorrhea. Again, any sort of chronic illness, especially tuberculosis, could also lead to this, and tumors. The ovarian causes in primary amenorrhea, the Turner syndrome, gonadal dysgenesis, primary ovarian failure, oophorytis. Most common is tubercular lesion at the puberty age, and radiation in chemotherapy, sometimes for other pathology which has been done and which causes amenorrhea. Secondary amenorrhea could be primary ovarian insufficiency. Again, oophorytis, which I told you the commonest cause is tubercular, which is very common. We have seen tubercular infection involving both the ovaries, completely destroying the genital organs. Then radiation, chemotherapy for lesions which can cause secondary amenorrhea. Genital outflow tract problems for the primary amenorrhea, it could be imperforate hymen leading to hematocolpus and abortus. Then transverse vaginal septum, or there could be non-canalized vagina, androgen insensitivity, or there could be intersex disorders. So we have to really thoroughly find out the reason and accordingly treat. Secondary amenorrhea, the genital outflow tract, most common cause is uterine synecdoche. And this Asherman syndrome is commonly seen after repeated curettage of the uterus or some cases of genital tuberculosis. Other causes of primary amenorrhea could be that she has not attained menarche and she becomes pregnant. Rarely, PCOS may start periods very late. Thyroid disease, Cushing syndrome, and Addison's disease are very important causes of primary amenorrhea. So if you have a case of primary amenorrhea, if genital organs are all right, she should be investigated for all these things. The secondary amenorrhea, it may be that during the period, lactation period, something she become pregnant and has become amenorrheic. PCOS, use of contraceptive, hyperprolactinemia, thyroid disorders, late onset of congenital adrenal hyperplasia, Cushing syndrome, and Addison disease. So this all can happen in young reproductive age group, leading to secondary amenorrhea. Next, we come to another important symptom, which is dysmenorrhea. It is most common. The pain could be absence of any organic lesion, but it could be also in presence of some form of organic pathology of genital organs. The pain in the lower abdomen, back, thighs, and it could be associated with headache, nausea, diarrhea. The causes must be evaluated If pain persists, basically an ultrasound, even of young adolescent, should be done to rule out pathology, and if need be, endoscopy to be done to diagnose endometriosis. Because endometriosis is a very common disease of young adolescents, and you could miss it if you take painful cycles as a common thing, which is usually taken by the families. Now, association of other clinical entities with menstrual irregularity. I think we have discussed all that because the pituitary gland produces LH, FSH, prolactin, ACTH, thyroid, thyroxine, and adrenal glands, cortisol, androgens, pancreas, insulin, ovaries, estrogen, progesterone, androgen. All that affects various conditions could be there, which we have already discussed in detail. Now, evaluation of the menstrual irregularities is very, very important. And before we discuss about treatment, we should think about preventive aspects. And it is very important to aware the young adolescent and their families about normal menstrual cycles, what abnormalities could occur during their menstrual period, when the girl and the family should be alert. They should be asked to keep a menstrual record, and if there is a problem, it should not be taken as normal, and medical consultation should be done to rule out the diseases. Now, what irregularities require evaluation and makes the family and the patient and the doctor alert? So, these are some important conditions. I think we should think about it, that the menstrual period, it has not started within 3 years of thelarchy, or even up to age of 15 or 14 or 15, she has not started. If the girl has started showing signs of hirsutism, weight gain, and there's history of excessive eating disorders, or the girl is too thin and suggestive of excessive exercises, we should be alarmed and should be alert. If the cycles occur more frequently than every 28 days, 21 days, or less frequently than every 45 days, which means even they are early, it is also abnormal. And if they are late, then also we should be alarmed. If the cycle occurs every 3 months, there's a gap of 3 months for one cycle, we should be alert. If the cycles last for more than 7 days, which means the bleeding period is prolonged for more than 7 days, or there's excessive blood loss during the menstruation, which means the pads are soaked every 1 to 2 hours. Or the woman gives history of heavy bleeding and is associated with history of bruising or bleeding from other parts of the body, what should be alarmed and necessary action should be taken. So, delayed menarche, primary amenorrhea, menorrhagia, oligomenorrhea, secondary amenorrhea, all these conditions need proper evaluation, proper investigations, and accordingly, they require treatment. They should not be neglected. If any woman comes with perimenopausal or menopausal irregularity, she should be also taken into account for investigation. But the most alarming is a woman who comes after she has stopped her period for 9 months and she comes with a recurrence of bleeding, postmenopausal bleeding, a very alarming situation, and should be thoroughly investigated because the commonest cause of such type of bleeding is malignancy from the genital organs. Now, how do we proceed to diagnose these menstrual irregularities and reach to a conclusive diagnosis? The most important part is the medical history, a detailed history about the menstrual cycle, about the date of menarche, age, family history, history of associated diseases, medical history like diabetes, blood pressure, kidney diseases, liver diseases, all should be taken into account. Any history of coagulopathy, any history of drug intake, all should be noted very carefully. Then we come to physical examination. A detailed physical examination of the woman should be done, inclusive of blood pressure, detailed systemic examination, detailed abdominal examination, per vaginal and per speculum examination. It is very, very important in unmarried girls, young girls. We cannot do a vaginal examination, but the rest of the examination are mandatory for even young adolescent. In the blood test, a routine test should be done to know the complete hemogram. Tests for medical conditions like diabetes, kidney functions, liver functions, coagulopathies, and any special tests needed should be done. Many times we need hormonal tests which are needed, like hormone levels of FSH, LH, AMH, testosterone, 17 ketosteroids. So whatever tests are necessary should be offered to the patient and should be done. Ultrasound examination is a basic examination which should be done almost in all patients who come with menstrual irregularities, because by that we will be able to find out about the size of the uterus, any associated tumors on the uterus, like fibroids, adenomyosis, any associated disease of the ovaries. Then we can find out about the endometrial lining. And if we necessary, we can even do an advanced test like MRI and CT scan. Transvaginal ultrasound is very informative for genital organs in younger reproductive age group patients and all perimenopausal and menopausal women. It should always be done, especially in menopausal and postmenopausal, to find out about the endometrial thickness, which is very, very necessary. Saline infusion sonography, many people are not doing it. Instead, now they are doing 2D or 3D ultrasound, which gives all the information. Hysteroscopy and endometrial biopsy are very informative, and when indicated, it should always be done. And hysteroscopy is very, very useful to rule out any intrauterine pathology like polyps and submucous myomas for abnormal uterine bleeding. Hysteroscopy is also very important in perimenopausal, menopausal, and postmenopausal women to rule out any endometrial malignancy. As I said, in between bleeding phases in women above 35, pap smear should always be done, and local inspection of the cervix should always be offered, because sometimes there could be polyps hanging out causing irregular menstrual bleeding. So all this investigation I've told you in detail, whenever needed, should always be done. In young girls, on ultrasound, if you're not able to find out the cause of abnormal uterine bleeding or her dysmenorrhea or pain, many a time diagnostic laparoscopy may be a tool to clinch the diagnosis of those patients. Sometimes endometriosis could be diagnosed on laparoscopy, and accordingly, the girl can be treated. Now, the common treatments, the menstrual irregularities, after investigation, actually we take the proper decision. But in anovulatory bleeding, combined oral pills are very, very effective. But sometimes if they are not able to tolerate, you can give cyclic progesterone. And the most important thing, if there's any underlying cause, first treat that cause. In ovulatory bleeding, if there's a cause, the cause should be treated. If no, it is dysfunctional uterine bleeding. I have found insertion of a hormone-releasing intrauterine device very, very effective in these women, which can be kept for 5 years, and it really regulates the cycles and stops the bleeding. Medications containing progestin, tranexamic acid could also be used, and sometimes even combined oral pills could also be effective. They could be effective as a contraceptive as well as regulating the cycles. Structural irregularity in effective medical management, because there would be medical management fail. So if there are polyps or fibroids, it should be removed. If that is not effective, or all medical treatments have failed sometime, or if a patient is not operable, uterine artery embolization is a wonderful alternative to cure the bleeding. We used to try, still sometimes we are doing a endometrial ablation and TCRE. And in the end, the last result, we should have tried to avoid as much as possible, because there's always a feeling, save uterus. But if need be, if the life of the woman is in risk, hysterectomy may be answer for that. So we come to the SCOG recommendation about menstrual irregularities. Clinicians should educate girls and their caretakers about what to expect of a first menstrual period and the range for normal cycle length and subsequent menses. I think there's a large work going on this. Lots of these classes are being taken by we gynecologists into the school program, and school visits are done, and girls from class 7 to 10 are being given these lectures to educate them about this. Once the girls begin menstruating, clinicians should ask at every preventive care or comprehensive visit for the patient's first day of her last menstrual period and the pattern of menses. So whatever disease problem they come, you should always inquire about the menstrual cycle. Identification of abnormal menstrual pattern in adolescents may improve early in the pattern of menses. It is important for clinicians to have an understanding of the menstrual pattern of adolescent girls, the ability to differentiate between normal and abnormal, and the skill to know how to evaluate the adolescent girl patient. So friends, we have come to the end of this discussion, but my take-home message is that as a clinicians, we have to be very, very alert. We should not be able to miss any condition. Otherwise, we will be facing effect of this under the women who may, because of PCO, may suffer later life diabetes, cardiac disease, other problems, hypertension, many other ovarian malignancy, endometrial malignancy, and all other things. Similarly, in reproductive age group, do not miss other causes of abnormal bleeding like fibroid, adenomyosis, polyps, cervical polyps, and perimenopausal, menopausal. Please rule out cervical malignancy, uterine malignancy, ovarian malignancy, all these conditions. Sorry, my throat has been bad, but I do hope I've been able to convey the message to you all. And now I will hand over the stage to Shrikant, who can now take over from me. Sorry, Shrikant, my throat was very bad really today.
I'm sorry, ma'am. Actually, we are taxing you. It's indeed such a pleasure to listen to you. It was like I was back sitting in my classroom, and I was actually taking notes. It's like your experience and the flawless flow. Absolutely perfect, ma'am. Thank you so much for your time. Maybe I think like a couple of questions. Is it possible for to take, ma'am?
Yeah,
Right now?
yeah, sure.
Yeah, maybe I think I'll start with the initial questions. So many doctors have put across that many parents show resistance or apprehensions about HRT. So, HRT, ma'am. Dr. Parvati Patnaik says in case of delayed periods age group of 12 to 16, how long we must wait and what is the actual treatment? And Dr. Naina Velopure asked at the age between 15 to 20 years, what should be given to regulate the menstrual cycle instead of hormones? And one more, Dr. V says menstrual irregularities in very young girl, 12 year. What do we do to manage such teenagers? So maybe I think your experience about safety
Yeah.
of HRT and further about this, ma'am, would be helpful for the
To all the
clinicians.
people who have asked this question, first thing I will really like to tell them that your evaluation of the girl is very, very important. You need to really find out if she has not menstruated by the age of 16. We cannot sit quietly. We need to find out what is the cause. You will not believe that there was a girl who had come whose uterus was normal. Ultrasound showed a normal uterus. Their hormones were level was normal. In spite of my all hormones, there was no withdrawal bleeding. The passage was normal. And to my surprise, I did a laparoscopy on her and I found she was suffering of extensive genital tuberculosis. So sometimes unexpected things come out to for your cure. And if we had not caught her, maybe the things would have spread further down. So if she is not menstruated by the age of 15, I think we need to be alarmed. We should like to work up, do her ultrasound, do her hormones levels, and if need be, one should not hesitate to do endoscopy to really diagnose these girls. And many times, even if you find that the only problem you could face was a size of the uterus was probably small, if we put them on these girls on cyclic estrogen progesterone therapy, and we have been able to achieve menarche in these girls. So they were not menstruating. They came at the age of 15, 16, 17. There was no menstruation. The only cause we could find was that the size of uterus was hypoplastic. Other factors were all normal. Vagina was normal. Everything was normal. And we put her, because there was no menstruation, we put her on date-wise cyclic hormone therapy. And in 6-8 months, we found they started menstruating. Some of these girls we found, we did indirect tuberculosis tests. And yes, tuberculosis is very common in north of in UP and other places, north side. Many cases of genital tuberculosis are here. So we sometimes like to investigate them on those lines also. And if we find positive, along with the hormone supplements, we put them on anti-tubercular treatment also. And we found they started menstruating. So be very alert. Do not wait 16, 17, 18 years, because probably you will miss the train and things would be too late. For abnormal uterine bleeding in young adolescents, really it is a very, very tricky situation, because parents are very afraid of giving hormones. As soon as you write treatment, they would ask, hormone? To my young girl, hormone? Many times you need to give small doses of progesterone only to regulate their cycles, because till the age of 16, they are not ovulating. So mostly these are anovulated cycles. And once they start ovulating, probably the cycle becomes regular. So if they are having abnormal excessive bleeding, you need to support them. But if the cycles are regular, or they are delayed or coming delayed and very infrequently, or she's amenorrheic 5-6 months, then she has a period, don't bother. Tell them by the age of 16, 17, once she starts ovulating, the cycles would be all right. But in those cases also, the ultrasound should be done to see the ovaries and the uterine size. The diagnosis should not be missed. Just on symptoms, we cannot let her go home and just wait.
Right, ma'am. Right. So in other words, you will have to see the risk benefit ratio and take a call, isn't it, ma'am?
Yeah.
Right. Maybe when you are mentioning about anovulatory bleeding, how can we clinically differentiate between ovulatory and anovulatory bleeding, ma'am? This is one question from Dr. Nagma.
Ovulatory bleedings are usually cyclic. They come every cycle, and the prolonged bleeding they would be. And anovulatory are usually acyclic. They are too quick, short cycles or delayed cycles. But you can only confirm only either if you do a follicular study for 14 days, or endometrial biopsy is the only answer to check on that. But hardly it matters. Many times it doesn't matter whether ovulatory or ovulatory. Most of the time the treatment is almost same. So You can do it. Even in anovulatory bleeding, LHC, IUCD is effective. So it doesn't matter if you're doing it only in ovulatory bleeding.
Fine. One second now. So in case of anovulation, when medicines are given for correcting ovulation and followed it by follicular study, Dr. Neha says sometimes it becomes a hemorrhagic cyst. Why does this happen and how do we correct this?
If the patient has really, you've given drug for ovulation, probably the follicles grew up, they collected and became hemorrhagic follicles. So maybe the next cycle or next cycle, she would be okay. So this cycle you put her on 21 days oral pill, start the next cycle from day 2, and maybe in second or third cycle she would be okay.
Fine. Thank you, ma'am. And Dr. Nagmas, another question was why there has been raise in PCOD cases in young girls these days. Any suggestions from family physicians to these girls? Would it be helpful?
What I find is the less of exercise, the dietary habits, outdoor exercise are almost nil. This all has affected because last 2 years I'm also finding lots of young girls coming with menstrual irregularities. And what I advise them, diet regulation, open air exercises, skipping, jumping, all those exercises, advise them. And I think 2 or 3 cycles, you regulate them hormones, progesterone only, and I think cycles would be all right. But main thing is weight correction is very, very important.
Unfortunately, this tiny virus has made us stay all indoors. Maybe that has added them.
They are just eating fast food and sitting at the computer, laptops. That's what it is.
Very unfortunate, ma'am.
Last week I saw a girl of 123 kgs. She was 14 years old, 123 kgs. And I asked her mother, what has happened? She said, this is Corona, what I had done to her. She was not like that. She was just sitting and eating and sitting on the laptop for her classes. And this has happened, what has happened to her.
Very,
so
very
you can see what damage it has done to the young girls and boys.
Absolutely, ma'am. It's actually like a very vicious cycle. I'm sorry. Moving further, ma'am, Dr. Vaishali Kurre, she asked, what are the reasons for cramps? Any tips for management in clinical practice?
For menstrual cramps, first thing you need to ask, are they just premenstrual and they subside with the menstruation? Mefenic acid is the drug of choice for them. Give them with the onset of cycle. As soon as the pain starts, it should be taken. And they should be advised outdoor activities, exercise, and the support of mefenic acid. But if the pain does not subside with the flow of the menstruation or even persist in the postmenstrual period, one must investigate that woman or girl, whosoever is, for endometriosis or for any other intertwined cause for causing this type of pain, and then the cause has to be detected and treated.
Thanks, ma'am. Dr. Sandeep has asked, what is the most common cause of dysmenorrhea in multipara women of age group around 35 to 37 years and its management? Maybe I think should we look at secondary dysmenorrhea here, causes and treatment, ma'am?
Yes, we have discussed secondary menorrhea and the age 35. I think one should look for the uterine conditions. There may be a fibroid, maybe adenomyosis, some sort of maybe uterine polyp. So some sort of thing, maybe secondary pathology would be there, and that may be causing. So we must rule it out. And I think if there's no cause, sometimes you may just give a mefenic acid and things would be all right.
Sure, ma'am. That was Dr. Sandeep. Dr. Gansham asks, is there any role of thyroid disorders in irregular menstruation? And what is
very
the incidence?
Yes, we discussed it. Thyroid has a very important place, and all young girls and all women should be investigated for thyroid.
What's the incidence in a country was his next question now.
It depends from place to place. Like in UP, in Gorakhpur, you'll find many have, because there are endemic areas for thyroid. So it varies from place to place. You just cannot have a regular incidence, but it's quite, thyroid dysfunction is very, very common now these days.
Thank you, ma'am. Not very sure if I can ask this question. Is there any significance of the color of discharge? Because Dr. Deepmala says, what about pink color menstrual discharge? Dr. Pechimed asks reasons for brown discoloration and reduction of simultaneous reduction of menstrual flow. Is there any correlation?
Yeah, this would be taken into oligomenorrhea, which means a scanty infrequent cycle periods. So we have to find out the hormone levels should be tested, the size of the uterus should be tested. Ovarian functions are very, very important. Patients going for ovarian insufficiency or there's a size decrease into the uterine size decrease may be facing this type of oligomenorrhea. We must investigate. If the hormone levels are all right, you just find that the size of the uterus is somehow hyperinflated. Many times after delivery, after 6 months, 1 year, after lactation, you find the uterus has shrunken down. Or when patients who are on Depo-Provera, the size decreases very much. Those patients may face oligomenorrhea, and then you have to stop Depo and put them on estrogen and progesterone.
Thank you, ma'am. A couple of doctors have put across case studies, like very short case studies. Would you be able to give them some suggestions? Dr. Chitra Rekha says a 24 years unmarried female patient who complains of amenorrhea from past 4 to 5 months. She has to take medicine for withdrawal bleeding, and without medicine, she never gets her period. Reports showing PCOD, but her FSH, LH, MH, prolactin, testosterone, and insulin, everything has come out within normal limits. How can such cases be tackled? And she is also having a family history of similar complaints, her mother and sister, and menopause started at 30 years of age. So she's worried a lot, it seems, this 24 years unmarried patient.
24 years unmarried, one test I will advise her to get it done, her serum progesterone level on day 21. Find out, that is very important, and she should do an ultrasound and size, find out about size of the ovaries and her, because are the ovaries showing any evidence of PCOD or not, and also find out about size of her uterus. Is it showing any?
What she highlights is PCOD. The reports are showing PCOD, but all our investigations like FSH, LH.
What is showing? The ultrasound is showing PCOD.
Yeah, ultrasound is showing PCOD.
But they say that only one condition you cannot go. Biochemical, one biochemical should be there. So ultrasound plus one biochemical marker should be there for diagnosing it as PCOD. So I would request Chitra to get her serum progesterone level done. If she finds his progesterone levels are low, maybe if supplements are in the second half with progesterone, I think her cycles will regulate from 16 day to day 10 for 10 days.
Thank you, ma'am. Dr. Chitralekha, hope that answers your query. Dr. Parul Kumari Thakur, she says one of her patients complains of heavy bleeding for a month after the history of amenorrhea for 2 months. But her urinary pregnancy test is negative and USG is within normal limits. What could be the cause?
This is typical anomaly type of bleeding, which we used to call metropathic pattern, metropathia. So this is a anomaly type of typical bleeding, and she should put her on oral pills for 3 to 4 months, and then if she is wanting issues, then she should put her on ovulatory cycles.
Sure, ma'am. Dr. Parul, hope that answers your query. Dr. Archana Agarwal, she's asked for investigations to be done in perimenopausal menstrual irregularities. And Dr. Rajeshri asked you to a little bit elaborate on perimenopausal menstrual irregularities.
Perimenopausal menstrual irregularities are very, very important part of menstrual irregularity, because this is the group which may, if you are not properly diagnosed, may present to you with malignancy or other problems. We are not bothered if the periods stop, but if there's irregularity, a thorough examination should of the patient with vaginal examination, speculum examination, pap smear, and with needed colposcopy should be done. Ultrasound, vaginal ultrasound in detail should be done, and her hormones level, especially hormones like thyroid, like prolactin levels are very, very important, which should be done. And Then if you find that her endometrium is showing any polyp or any thickening or something, hysteroscopy could be added into the diagnostic procedure along with diagnostic curettage. So this investigation could be done if you find everything normal. Then for this irregularities, she could be put on low pill, combined low pills with 20 microgram estrogen, milligram estrogen should be there, very low pill, low level, low estrogen pills. She could be put on 4 to 5 months, and I think perimenopausal bleeding would be treated.
Thank you, ma'am. Dr. Smita, she asks, her patient age is 40 years, who has a simple ovarian cyst measuring 29 by 23 millimeter with posterior wall fibroid of 10 by 7 millimeters, having scanty menses. Should she wait and watch, or is there any immediate investigations?
I don't think. What age group is she?
She's 40.
I don't think there need be for this 20 size, 20 mm size cyst on 10 fibroids. I don't think it is anything to do. Only thing she should look at only the endometrial thickness, and she should be worried about that only. These things are not going to affect at all.
Sure, ma'am. And going further, Dr. Padmakshi, she asks, can we save the uterus and ovary in final stage of complications of PCOD or uterine cyst or fibroid? Because many a time fibroid means it's always advised hysterectomy.
No,
so
no.
That's what
now,
she has
even at the age of 40, 42, we do not do hysterectomy. We take out the fibroid and do a mammectomy. So I don't think there is any indication of doing hysterectomy there.
Perfect.
But I would request everyone to avoid hysterectomy, because there's always alternative to hysterectomy. And LNG, IUCD I've been using for a long time, and I've been able to avoid so many hysterectomies because of that. So please, I will request all the people who are joined today to work up your patient very well. Don't take a first decision of hysterectomy. There are multiple alternatives to save that uterus, because we want to save that uterus at least till she's become 45. Yeah. So I don't think for that any hysterectomy is needed.
Dr. Manisha Garg, you also had a query on this uterine fibroids. I hope that answers. Is there any diet for irregular menstruation? Dr. Sakshi Pandey wants to know, is there any specific diet that you can suggest for those who are suffering from this irregular menstruation?
As I told you, very high fatty diets, weight gain, all that are against this menstrual cycle. So they always disturb the menstrual cycle. Even if your liver gets fatty, your liver functions are disturbed, that will affect your cycle. So diet is an important part. We should always advise them to maintain their weight, and accordingly be on more of fibrous diet and less of fatty diets. That should be advisable for them.
Sure, ma'am. Like 30 plus women are having oligomenorrhea these days. It's on the rise. Dr. Pooja Rajput wants your advice. Is there anything that needs to be advised to these patients, or they have to ignore this?
I think that's not a normal thing. I mean, 30 plus women are not having oligomenorrhea. They may come even with menorrhagia and other problems also. But if some of our patients are having it, she should try to find out, are they on oral pills? Because many times prolonged oral pills can also cause oligomenorrhea. So these young girls are taking pills or IP pills, or so many things in between they are taking. So one has to take a proper history and try to find out cause.
Got it, ma'am. Maybe I think even like you're right. Dr. Jyotsna Sinha, she says she has a patient 30 years unmarried, and she has menses twice a month since few months. How do I tackle this complaint? Twice a month. It's almost 15-day cycle.
Yeah, so then you need to take all the history in detail, and how many cycles she's been having, too frequent cycles. Was she taking some drugs for any other purposes or something? Sometimes they are taking some drugs for some other neuropathology or depression drugs or other things. So some neurological drugs also affect the menstrual cycles also. So all those history has to be taken, and then do an ultrasound and find out if everything, organs are all right, and do her hormone levels. If they are all right, put her on pills and then check for some time, and I think she should be able to be controlled with those combined pills within 3 to 4 cycles.
Thank you, ma'am. Dr. Sarojini Mohanty, she
अरे
has.
कितने लोग ने join किया?
Madam, that's a very nice question, ma'am. 2,500 was the registration. We had around 600 plus viewers live, and this will be recorded and also will be put across on our MedTalks portal.
Thank you. It's nice. सब लोग सुन रहे हैं तो अच्छा ही लग रहा है.
Absolutely, ma'am. Absolutely, and that's why these many questions, ma'am. It's actually their privilege also to take advice from one of the senior most in the country.
Thank you, Srinath.
Ma'am, Dr. Sarojini Mohanty, she asked, is there any role of phytoestrogens in the management of menstrual irregularities, and how herbal drugs are useful in regularizing irregular cycle?
What we have been learning from very long time, that Ashoka products are really able to help into the cycle regulation, and that is why all the uterine tonics are made through the Ashoka thing. And we also, as senior person, we also prescribe it. But other herbal drugs like phytoestrogen, I have not tried in young girls, but I have been using it for postmenopausal women with their symptoms. That I have been using it. Most of the times in reproductive age group or in young adults, we would not like to try these drugs because their whole reproductive life is ahead, and we do not want to try these drugs. And the best option would be to work up this patient and properly treat them rather than putting them on vague drugs to regulate cycles.
Thank you, ma'am. Ma'am, just there is an update. I'm sorry. I think what I said around 500 plus was the initial one. 900 plus is the current viewers online. One more question by Dr. Sneha. She's asked whether DUB and AUB are same.
Yes. Previously, we used to call abnormal uterine bleeding. Now, the second name was also dysfunctional uterine bleeding. So both terms are same.
Thank you, ma'am. Any hints about leukorrhea, because that is also one of the main complaints that women come to family physicians. Do you have any suggestions regarding?
Yeah, leukorrhea is a very common symptom. The girls even come to us and that their mothers bring them. What we need to do is that it's a very common complaint with which they come. We need to only ask the mother or the child, is there any associated smell, itching, any other problem? If such things are not there, they need to be explained to maintain the local hygiene. And secondly, they need to be explained that as they grow up, the organs are growing, and it's natural to have a moisturizing discharge from below, which they should take it as normal, because this is not going to affect their bones. They have a feeling, a notion that probably this is going to weaken their bones and their general condition or health would be down. So they need some counseling and awareness, and some sort of general tonics and things would be prescribed, and local wash should be advised to these girls.
Thank you, ma'am. Last, I think one more question, if you can permit, my ma'am. Chronic history of spotting. Spotting when presented, what are the diagnoses of concern which should be ruled out?
Anyone who's presenting with a chronic spotting, one should be alert. You cannot let that patient go without examining her. The common cause, if she is a young reproductive age group, it could be a small polyp into the cervix or endocervix. It could be erosion, an ulcer onto the cervix, which could be causing spotting and bleeding. And it could be a tubercular lesion under the cervix, which could cause this intermenstrual spotting. Or it could be a malignancy which may be starting, especially in perimenopausal women. If they come with the spotting, a thorough examination should be done. An ultrasound should also be done to find out about rule out any intrauterine polyp, which can also cause this type of abnormal in-between spottings. So mostly spottings are because of the local lesions. It does not really say about hormonal influence on that bleeding. So we must be careful for the local examination and try to rule out all those conditions.
Thank you, ma'am. I would wind up with one more question, ma'am. Safety of cervical vaccine, especially in early menarche.
100%. I'm one of the most advocating person for cervical vaccine. None of my patients from my clinic will go without vaccination. Two things I do a PAP and HPV testing for all my patients and cervical vaccine up till age of 45. I prescribe to each one. And there is some financial problem with that. I talk to them, tell them that if disease comes, the expenses would be much more than what you are spending today. Try to collect money, arrange for it, and the schedule is 1, 2, 6, so 3 injections they can manage. Now we are so far using quadrivalent vaccine so far, but now nanovalent vaccine has also come, and which is against 9 genotypes, which is very expensive. So we have not been able to use it too often. Maybe the prices would come down, we'll use it. But my request to each gynecologist, every practicing physician is, please advise this vaccine to all your young girls starting from the age of 11 to women up to age of 45. Even if their smears are not done, at least 60% less chances of getting cancer after vaccination is there.
Thank you, ma'am. I'll take a permission to wind up. Before that, let me once again highlight the latest numbers have crossed 1,000, ma'am.
Okay,
I think
you.
thank you very much for your valuable time. And maybe like if I'm not too intrusive, I would like to ask. You said for leukorrhea, some local washes. Are you highlighting something like, is it a vaginal water douche or like any
No,
specific?
not douche. It's a lactic acid wash. That's all.
Okay, fine. Like whatever is available as intimate
Available in the
washes.
market, yeah.
Right, ma'am. Thank you very much. I hope I think all our participants of today's webinar would be taking home such a feast of knowledge, and I think there will also be several more taking advantage of your knowledge, ma'am, because we are putting across this recording on our platform as well. So this was an initiative from our company, Himalaya Wellness Company, in collaboration with IJCP. We really thank you very much for your valuable time, and maybe I think we'd once again request you to have some other topics in the coming days. And sorry for taxing you. Sorry for taxing your throat, ma'am.
Too happy to do it. Thank you very much.
Thank you very much, ma'am. Have a wonderful evening. Namaste. And thank you all participants. You can download your participation certificate from the portal, and we'll shortly come up with many more such knowledge fees